everyone, and welcome to today's Echo Clinic. Before getting started with introductions, we would like to share a general reminder to maintain confidentiality by not releasing any personal health information of the individuals being discussed today. Please mute yourself when not speaking by clicking on the microphone icon in the bottom left corner of your Zoom screen. Audio participants, please dial *6 to mute and *6 to unmute. Prior to speaking during this clinic, please introduce yourself by saying your name and location. This allows those who are using audio to follow conversation as they cannot see who is speaking. So we'll start in the top left-hand corner. Patricia, introduce yourself and where you're from.
Hi, good morning. I'm Patricia Walters, and I'm a behavioral health specialist with the community care team. I work in the Blandon Hub and Hamilton 3080.
Welcome. Next, Diane.
Hi, I'm Diane Beery. I am with Department of Family Medicine at Lehigh Valley Health Network.
Welcome. Kelly.
Hi, Shelly Steiner, coming to you live from my bedroom this morning. But anyway, I am the program director at Peer Drug and Alcohol, and I have my own private practice. Hi, everybody.
Welcome. Hi. Yunji.
I'm Yunji. I'm one of the family medicine residents at Family Health Center or Valley Health Partners.
Is Kevin there, or maybe you want to come back? Kevin peers in from the other. Kevin Manfred. We'll come back to Kevin. Christopher?
Good morning. My name is Christopher Nine. I'm a behavioral health clinical coordinator with the community care teams.
Hello and welcome. Sophia?
Good morning, everyone. Sophia Harbove here, BHI caseworker for the PACMAT team. Very happy to be here. So good morning.
I apologize that I don't know your name, but C7638 will tag your name once you introduce yourself.
Good morning. I'm Valerie Guerra, and I'm the behavioral health specialist on the community care team.
Okay, welcome. Valerie, which practices are you at?
At the Palmer Hub. So I work with Nazareth Family Medicine, Bangor Family Medicine, Bath Family Medicine, Family Medicine at the Eastern Health Center, and Internal Medicine on Nazareth Road.
Cool. Just as an aside, sorry, team here, but we're really eagerly recruiting those guys, so help us out.
Okay.
Anybody that you think will be willing or ready to talk, just let us know.
Okay.
Heather?
Hi, I'm Heather Cromer. I'm a behavioral health specialist with the teams. I'm at Bethlehem Township, and I work with West Broad, Hellertown, Easton Avenue, and MATLAB.
Okay. Anyone hear us, Lori? Lori, can you hear us? We're hoping for you to invite.
Hi, I'm Laurie, CCT Behavioral Health Specialist. I work with the Whitehall Hub, which includes Whitehall Family Medicine.
Awesome. Melissa.
Good morning, everyone. Yeah, Melissa Taveras, here as a faculty for Counseling Solutions at the Lehigh Valley, but time is being covered by the PACMAT as a BHI for team. So thank you.
Jessica. Jessica?
I'm Jessica Morris. I work with CCT here in Fogelsville. Soon to be at Center for Women's Medicine next week at 17th Street.
Is that right? Congrats. Brilliant.
Hi, I think you said Jillian. I'm having a little bit of a hard time hearing, but if it was me, sorry, Jillian Beecham on the core PACMAT team, PACMAT faculty. Good morning.
Morning. Paige.
Did you say Paige?
Yep, Paige.
I'm Paige Roth. I'm program coordinator for addiction recovery services in the Department of Emergency and Hospital Medicine.
Gina.
Hi, I'm Gina Hills, program coordinator for Center of Excellence at Neighborhood Health Centers of the Lehigh Valley and ECHO faculty.
Welcome. All right. And then here around our table, Naomi.
I'm Naomi. I am an integrated health specialist, echo specialist, and a CRS.
And Jasmine, loudly. I'm Jasmine, and I'm with Neighborhood Health Center in Lehigh Valley, who registered here, who has recently passed awards as a family nurse practitioner.
Yay!
And I'm communities have to celebrate together, right? That's what we do. And I'm Angela Thuram, along with Jillian, the other co-director for the PACMAT, and I'm the director here for the Neighborhood Health Centers Project ECHO. So welcome. We have a great case. Oh, Kevin has reappeared. Kevin, you want to introduce yourself real quick?
Yeah, hi, sorry about that. I've been struggling to get myself situated this morning. Good morning, everyone. I'm Kevin McNeil. I'm a family physician out in Hamburg and part of the PACMAT team.
And I see we have Mary also. Welcome, Mary.
Good morning. I will mostly be non-video because I'm not yet ready for public appearances. However, I'm a family physician at Valley Health Partners Family Health Care.
You look beautiful, and you, I hope, enjoyed your vacation. A little bit. All right, so we have an awesome case.
Abby?
That is.
Abby,
yeah.
It's Gail too. Gail Stearns here too, the administrator for psychiatry. Yeah, I'm on the phone now. Yeah.
Gail, how do you want to introduce yourself?
Well, you know, I'm happy to be here, and I'm the administrator for psychiatry. Glad that this is moving along well.
Yay. All right, Yunji, one more time. I'm going to do the lead-in. Yunji, we have an awesome case today, and it has a couple of little ancillary cases that are orbiting around it that we can talk about. But Jasmine is going to pull up the slides for the case, and Yunji, Yamalisa can chime in. Let's go to that case, and while we're pulling it up, Franklin, do you want to say hi? Oh, he's still connecting. And sometimes that takes a little while. Franklin, do you want to introduce yourself? Welcome. Oh, you're on mute, love.
Here we go. Good morning, Franklin Ortiz. I'm the Behavioral Health Clinical Coordinator for Valley Health Partners, covering the community practices at 17th Street. Good morning, everybody.
Good morning. All right. Listen. Got a case today. Go. So usually with these slides are just developed from the template that you sent to us. You can go through it, add if you want to, ask for help if you want it.
All right. So I met this gentleman at Ripple. He's a 30-year-old Caucasian, non-Hispanic male. He wanted some help with non-medication treatment. He is not aware of the presentation and he did not help develop the questions. So for his strengths, he was very open to treatment and wanted to stop using. He's also resilient because he's had a fairly significant past history with incarceration and abuse, but still willing to open up to us. And he's also advocating for himself, and he is actually insightful. For our question, how can we increase the likelihood of continuation of care for unsheltered patients in the primary care setting? So some history and background for this patient. He, again, has a long history of incarceration and violence. He grew up with his father through age 16, and his father also has a history of incarceration. When we met him, he was about 4 months out from being released after spending about 10 years in and out of jail. Most of his incarcerations were due to assault, and then he was living in an encampment in the woods. When we had met him, he was robbed, where he used something and he just woke up and they had taken his money and his phone. So he came to Ripple to seek some services. He's currently unemployed. He does have a mother that is supportive and he does talk to her sometimes. And then he had 2 friends who were actively using that kind of, were part of the encampment, I believe. So for housing, he was unsheltered or homeless, unknown about the specifics about his education. For legal involvement, he was incarcerated for many years. For employment, he is unemployed, but he showed interest in wanting to work. So for some labs, he did have a UDS in the emergency room on March 13th of this year that showed amphetamines, benzos, opiate. He was opiate and codeine negative, and then alcohol was negative as well. For his substance use history, he uses heroin daily. He's used for about 13 years, I believe. And then he currently uses 5 to 10 bags. Last drug use was on July 23rd with 1 bag. He was reporting withdrawal symptoms such as aches, diarrhea, pain, nausea. He was still able to eat. He ate a sandwich in front of us. He was very tired, a little bit of sweating, tiredness, weakness, cold sweats. And he does have a history of sporadic methamphetamine and oxycodone use from friends. And then at times would binge on alcohol, and he does have 1 DUI. And then we had started him on buprenorphine 8 mg BID. So comorbidities for him, for medical, opiate use disorder, depression with anxiety, chronic hepatitis C, tobacco use, and alcohol use. Medications that we found on his list were Klonopin, clonidine, prednisone, Suboxone, hydroxyzine, Narcan, and Lotrimin. So in terms of the DSM-5 criteria, he basically met everything on the list.
You know, that's fine.
And then I believe he did not have a history of inpatient drug and abuse treatment, but he did complete outpatient in 2004. And then he was in active use when we met him, and then struggling with his cravings. And then he did lack support and was seeking NA meetings, and then also agreeable to outpatient treatment. But he was engaging in high-risk behaviors, again, the 2 friends that were also actively using, and we asked him to carry some Narcan. For what motivates the patient for change, I vaguely remember hearing him talk about a son that he had that recently underwent some kind of heart surgery at CHOP, but we weren't sure the specifics in the relationship. So proposed diagnoses for him: opiate use disorder, depression with anxiety, chronic hepatitis C, tobacco abuse, and alcohol use. Then his plan and treatment goals is to get on MAT and begin outpatient substance use disorder treatment, staying out of jail, starting hepatitis C treatment. So initially there was a CRS referral, assessing for MAT appropriateness, and then I don't know what PO stands for.
Probation officer.
For re-entry planning. And then for supporting his goals, he did want to be independent, live a healthier lifestyle. He really liked exercise, and then changing his eating habits. He was last physically seen by street medicine on July 24th. And then when we were looking up his case, Sophia found out that he was incarcerated at a state facility on July 27th.
Okay. So this young gentleman, 30-year-old, was new to care for the street medicine team, had been identified through participation in the Ripple Street Medicine Clinic and going to Ripple for resources. Been living in an encampment that was new to the street medicine team, unemployed with a history of incarceration and some inconsistent care, polysubstance use, depression, anxiety, hepatitis C, who came in with a diagnosis of severe opioid use disorder, but seemed open to treatment, possibly motivated by his son, and slipped through our fingers and ended up incarcerated again. About right?
Yes. He actually had an appointment scheduled with me, I believe July 28th, and then did not make it. So when we found out he was incarcerated, it made sense why he was unfortunately unable to make it. In a way, we were almost like, I guess, glad, I don't think is the best word, but he was safe because we had that really bad storm with all the flooding, and we were concerned, like, did his encampment get flooded out? And that's why he couldn't make it. So knowing that he's at least in an area that's safe and he's alive.
Right, and it's a sad commentary when we're happy to find someone's incarcerated, because that's a low bar, right? But there you have it. Great, so we're gonna open it up to questions, but first, can I welcome Jill? You wanna introduce yourself?
Good morning. I was on the phone earlier. I had childcare drop off. Jill McCambridge, CCT Behavioral Health Clinical Coordinator.
Wonderful, so glad you're here. All right, let's get some clarifying questions. What else do you wanna know about this guy? What questions do you have? What would you be thinking about?
I'm curious to know where he grew up. Is he from the Allentown area? Is he familiar with the Lehigh Valley?
Hi, Paige. Thank you. He is new to the Lehigh Valley. He came down here after his incarceration time. He is from one of the areas north. I don't know specifically from where, but one of the things that he mentioned often was that in his area, there was nothing, you know, when he went to Ripple and met street medicine, he was just very grateful that he was receiving help right where he was, and he was being met where he was at as far as recovery and physical space as well. But where he comes from, none of this is available according to him. So not sure specifically where, but not Allentown.
Hi, everybody. I sat in with Yunji and Yamalisa with this patient, and I distinctly remember him saying that he was from Carbon County. And yeah, like Yamalisa said, there were no resources, and he was just so thankful. He made many mentions about he would be able to go to Ripple and get a warm meal and, you know, just kind of get out of the elements a little bit. So that's where he's from, is Carbon County area.
Thank you so much.
Paige, why were you asking? Give us a little insight into the Paige questioning.
Well, sometimes people tend to migrate back to, you know, where they came from. And I was just curious, you know, where he grew up, to know like what kind of, you know, we know what services are available up in Carbon County. You know, and that might be a discussion we would have with him going forward if he would ever bring up, you know, the topic of going back home. You said he was in contact with his mother on and off, and if she's from that area, it's just something I like to know, because I think people often migrate back to what they know.
Thank you. Other questions? I want to know about this guy.
Sophia, do we know if he's on MAT now? Like, I'm not sure where he's incarcerated, but since he was started on it, sometimes that can be continued. I don't know if he actually started it. Do we have any idea?
Great question.
You know, I don't really know, but I think if we were able to make a connection with his case manager at the prison, they would probably give us a definitive answer. I think, yeah, Melissa, you and Gina, I kind of talked about, you know, reestablishing that connection so that we can coordinate reentry when he is out of prison.
Awesome. Okay. Thanks.
Great question, and it's relatively new, isn't it? That it said Cole something. What did it say in there about where he was incarcerated? Do you still have that? That was
SCI Cold Township.
Okay. But it's relatively recently that the state prisons and some county jails are maintaining people on. Thanks, Shelley. That maintaining people on MAT, and really all the state prisons should be doing that for anybody that's currently on MAT, either methadone or buprenorphine. So if we can make a case that he was on it, and we know that he did do the home induction and then he sort of slipped through the fingers, that maybe we could advocate for that for him. And maybe it's already happened. Who knows? It'd be interesting to see. All right, other questions. These are great questions. What are you curious about this guy?
I'd like to know a little bit more about what happened, you know, that led to his incarceration, both this time and previous times.
Mm-hmm. Yeah, and I don't think we had too much information on that, did we, team?
I was able to pull up his, I don't want to say, well, I just was able to pull up his docket sheets, and he does have an extensive history of retail theft, a lot of assault charges. So my inkling is that this just kind of coincides with his drug use to support his drug use while he was out in the community. And he was very open with it when he discussed it with us, that he had an extensive history, and, you know, he kind of didn't really want to live that lifestyle anymore. He was kind of, you know, done with prison.
Mm-hmm.
Yeah, I'll jump in because I you know, met him briefly at Ripple, and when my heart sank when he said he was incarcerated, because he really broke down talking about that, and that was it was really a really big goal for him. He's you know, he basically has to steal to survive, and he has to steal to not be really, really sick and in withdrawal, and he hates it. And he wanted to break that cycle really badly. And he just, when I asked him, you know, what it was that was important to him, what he didn't like about it, he said, I don't want to, he didn't want to steal anymore. Did not want to do it. And so, yeah. So that's probably I'm glad I agree, Eugene, I'm glad he's safe, but that is a heartbreak for sure. That was specifically his reason for wanting to become abstinent and enter recovery. So, yeah.
Also, one of the things, which is why we have that note of he never completed inpatient treatment, he really made it a point to state that because of his history with incarceration, he started using at age 13, started going to jail at age 16. And because of his history, the first thing that happens when he goes in front of a judge is they send him to jail. And he has never been given the opportunity to actually go into treatment and complete inpatient. So that's one of the things he mentioned a couple times.
That's a tough cycle. That's a tough cycle. And I think the statistics out there are that jail and prison is where most of our people are in an institution with drug and alcohol diagnoses, and it's really not a therapeutic setting. Okay, so we've learned that he's from Carbon County, been incarcerated, the cycle of the criminalized activity around his drug use has interrupted his treatment and put him in a place where he doesn't want to be. And that his sort of bigger motivation for how to get some help has been interrupted again. What else do we want to know about him?
So did he violate probation? Is that why he's back in prison? Or was it a new charge?
Unfortunately, I don't have the docket sheet in front of me, but I can quick pull it up. But the way it read, it looked like it was a parole violation. So he may have not appeared. Like I said, he was not from this area, so he might have been hiding out. We can only speculate, but we can revisit his docket sheet and see where he's at with things.
Because I was thinking if you can get a hold of his probation officer, or at least the probation officer in the county that he's supposed to go into, there may be a way that you can advocate for him to have treatment instead of incarceration and explain to them. I mean, you never know. The parole board is sometimes really hard ass, but sometimes they'll agree. So that might help.
Do we, everybody, do we know anything about Carbon County and their, what kind of resources do they have? Do they have a drug court, or do they have any other kind of alternate probation systems? No.
I'm not really familiar with Carbon County. I'm not sure if they do have, drug court or coordinated, reentry for these individuals. But that was something that the team talked about, was trying to establish contact with his case manager in prison, and perhaps, like as Shelley mentioned, his probation officer, just to have that, warm handoff and that continuation of care. And even, like Dr. Boucham said, I really felt for this guy. I really wanted him to do well, and he was really motivated for change. He just didn't have the resources.
Well, because he's a state, he's a state-owned person, which is unfortunate. The county can't even step in, so you have to go up to the state level. Because if he's in SCI Cool Township, the county doesn't even have control over him, which stinks. Because working through the state system is very difficult. But if you can find out a little bit from the jail, who his case manager is at the prison, maybe the medical department, and then there's a really good possibility you can get to his probation officer before his probation hearing and find out what it was. Was it a tech violation? Was it a regular violation? Did he reoffend? Because a lot of times with a technical violator, they only get like 3 or 4 months, and then maybe they can put on his green sheet that he can go to treatment in lieu of something else. So I don't know, it's worth a shot.
No, thank you, Shelley. I think that's a great idea. Just even having him know that we're concerned about him and that we're reaching out in some extent might give him some hope. And I mean, if he's coming back to this area, I mean, you know as well as I do, they never know when they're going to be released, and they're literally dropped in the middle of nowhere with nothing but, you know, the rest of their commissary money, and that's it. So yeah, I thank you so much for that.
Yeah.
Hi, it's Gina. I have a question. So he has no address, am I correct?
That's correct. So he was getting set up to use, street medicine has a sort of address program.
Okay.
So they were getting him set up to apply for benefits and so on with the street medicine address.
So that could be challenging for a state release. Carbon County does have drug court, but if he, like Shelley mentioned, if he's a state prisoner, the only good thing about state prison is Pennsylvania DHS has an initiative for them to work with Center of Excellences. So if he has opiate use disorder, you can reach out through the state prison, and they should be pretty receptive to you because of their initiative to work with the COEs. And you might be able to work something out for him based on him being a part of that population.
Great. Yeah, so I think in his case, since PACMAT is not a COE, that would either need to be through an HCLB or through treatment friends. And we don't have a treatment friends person here at the moment to help us sort that through, though Shelley knows a little bit about that COE. So we can think about that. But let's think about any more questions that we've got. Diane says, any information on his relationship with his mom, and can she assist? Interesting for those of us who were in the room about his relationship with his mom. Anybody want to comment?
I can comment on that. I mean, so hard to know what the real background is, but he mentioned his mom repeatedly, being close with her, and she's an important motivator. We then witnessed that street medicine loaned him a phone to call her, I think thinking that might help. And it was a pretty rigorous kind of shouting match for a good 20 minutes. Now, I think the other piece is that he was in bad withdrawal, so he was not feeling good. I think he was really hungry, but really nauseous. So he did eat there, as Yunji mentioned, but he was just not feeling good. So hard to say how that contributed. But I believe he said his mom, I think, cares for his child. And I think that's really important to him. And that what he mentioned about his child is that the night his child had open heart surgery at CHOP, he kind of tearfully described lying. I mean, he sleeps outside, kind of lying in his camp, and just couldn't sleep and couldn't get it out of his head. And he was just picturing his kid in the OR. And so I think that his mom is, if nothing else, the person who cares for his child, and I think who he's sort of desperate to, I think, be in touch with, at least because of that, if not other reasons. I mean, he mentioned her enough that I think he really does care about his relationship with her, but it really did seem rocky to me. Abby, I don't know what your impression was. We didn't really talk about that at the time, but there was a lot of shouting, and yeah, it didn't sound therapeutic. I think, Nani was a little concerned about it too at the time.
Mm-hmm. Angie, are you thinking about something?
No, I wasn't there for that phone conversation, but yeah, it was kind of hard to tell because I remember him talking about like, yeah, like I never listened to my mom. I did all the things like she told me not to do, but like sounded like he was trying to like repair the relationship with her.
Mm-hmm. And that can be a really uphill road sometimes. So I guess we caught it at a moment where there was a bump in that road, right? It was a loud conversation and hard to reel it in. I want to make a special invitation to all of our CCT folks. I know you guys have all sorts of great experience on working with people at various stages of readiness to their own change. I want to invite you guys, if you have any kind of question, there's no perfect questions and there's no bad questions. What are you thinking about for this guy?
Hi, it's Frank. I'm wondering if, do we know anything about any period of sobriety for the patient? Has he been clean for a while? And what was working for him in order to be clean? Any kind of strengths?
That's an awesome question.
That definitely is a great question. From the interview, there wasn't too much conversation as far as his sobriety time because he was mostly incarcerated. Therefore, most of his time sober was while in jail. After completing outpatient, I vaguely remember him mentioning about being able to stay sober for a little bit of time. I'm not sure if Sophia or Yunji remember more specifics. However, the piece that he did mention was after his after his outpatient treatment, that what was supporting him was being employed. But he probably ended up, either relapsing and reoffending or having some issues legally that led him back to jail.
So again, the most treatment he's had has been incarceration, which isn't treatment.
No, it's funny that you say that, Abby. He actually mentioned that while he was in state prison, that he was going through their drug and alcohol program, and he was like, "That's not even a program. It didn't help me."
Yeah. All right. So let's transition. We have a little bit already thought about some suggestions, but let's think about what would your approach be with this guy? What ideas do we have for resources or methods to get back? And what I'd like to do just for a moment is kind of trace how he came and what we were planning to do. And it didn't work out the way we planned, and that happens sometimes, right? But I guess Nani had heard about him from the Ripple team. They went out to an encampment that was a new encampment that was on pretty low ground by the river, by the Little Lehigh. She texted us because we were encouraging all of our clinician friends to just go ahead and reach out to us when you have a question or a case. She reached out because she was at the camp and he didn't have a phone, and she was just new building the relationships herself. And the street medicine team is very attentive to this notion that without that sort of trusted handing over, these relationships are tenuous, and there's not often enough trust built to actually be able to do the work that we want to do with people. So she FaceTimed me into the encampment, and we said hi and set up a time to meet him the next day at Ripple. And our team from the PACMAT crew that have all been checking in here all rallied around because we were trying to figure out what would we do. So Jillian was there. Yunji came to be the handoff for his primary care. Yamalisa and Sophia were there. Nyan was there. So there are probably more of us than there were of him, but he also brought a friend of his. He brought 2 friends along. And it looked like that was kind of promising and interesting. Yamalisa and Sophia were able to actually do a ASAM level of care assessment. And Jillian and Yunji and I all sort of saw the patient in some way or another. One of our glitches is that I can't prescribe, so thankfully I didn't have to. So Jillian was also able to step in and do that, and Nani went with him to the pharmacy to get some medication, and he did his home induction, but then he did not come back to his primary care appointment. We now know why, but in the meantime, we had a massive flood, and what I heard from Nani was that the encampments that they do go to regularly were under 4 feet of water. So everything was washed away for the people who lived there, and that this encampment was on lower ground. And I don't know if any of you all walked around the little Lehigh after the floods, but the water line was 8 feet over our heads when we were walking in the little Lehigh Parkway. So we were pretty worried about what happened, but we know that people in those encampments lost everything they couldn't carry with them. So that's a sort of piece, and one of the things we were worried about, and what we thought had happened, was that we've been too quick with the handover to primary care, and that we needed to sort of wrap around services for these guys a little bit longer in the street medicine world, and bridge them for a little bit longer, maybe before they were ready to go to the primary care setting. That's a hypothesis we get to wonder about still, because it turns out he was incarcerated. But his friend also did not come to his appointment. And I don't know, Sophia, did we look up the friend also?
I unfortunately didn't have all of it. I think it was, I was only given first names, unfortunately, but I can definitely do some research and see if they're back in the system and incarcerated.
Okay, so we can look at that too. And that person had also set up for appointment at the Family Health Center with Drew, and then set up for another one. So we talked to him, and didn't come to the second appointment either. So questions that came up were, what support do people need in that super vulnerable period during their home induction and stabilization on their medications, when their social determinants are more or less off the charts, living outside, no source of income, no fixed address, risk of incarceration, you name it. So what are some suggestions that people have for approach for him or for his friend who may not be incarcerated? What would we think of?
Well, Shelley and I have been having a little private conversation in the background, but with this particular patient, what she had suggested, since he's up in Cole Township and Shelley knows everybody everywhere, which is awesome, she suggested that once he's released, and if we are able to make contact, maybe he can be released to Conference of Churches, Lazarus House, and just, coordinate with the director there so we can have that warm handoff for him.
Mm-hmm. And Shelley, that's Henry who's there, right? Okay. Shelley, can you tell us a tiny bit about Lazarus House?
I don't know a whole lot about it. I know that it is a reentry program for individual males who have come out of prison. I worked a lot with the Conference of Churches over the last 20 years. They always have some sort of program that is put together for individuals to keep people off the street. Henry Perkins is a great person. He can figure out a way to get someone off the street if you give him a call. But Lazarus House is specifically for individuals coming out of jail.
In a kind of recovery house model.
Not really. I don't think, I wouldn't label it as a recovery house, but more like a reentry instead.
Okay. All these labels are so confusing, aren't they, team?
Shelley, and do you know if people can be on MAT at Lazarus?
Yes.
They can. Awesome.
Mm-hmm.
Awesome. That's I'm saying unusual, but sometimes I think it's hard to find sober housing where people can be on MAT. So that is awesome.
I agree. We need to buy a couple of houses for people that are on MAT. We have to do something because that is the biggest gap we have.
Yeah.
Right, and slipping into advocacy mode, part of what's interesting about Ripple as a partner is that they do permanent supported housing. So at a community level, that would be an interesting partnership. What other resources, ideas, thoughts? I'd be interested from the primary care point of view about, how do we help connect to the primary care? Think fair amount about the reentry point of view. Who was that nice phone number? Was that Gail?
Sorry, that was me. I actually forgot to mention that I have to be somewhere by 8, so I was trying to call in and see if I could connect.
Okay, great. I'd love some suggestions too for, and Yunji, I don't sort of putting you up there for the next couple of minutes, but what kind of suggestions do our behavioral health folks have or our primary care for a primary care doctor who's going to start seeing somebody and start to develop a relationship? What are some helpful tips for Yunji?
Well, so I have a suggestion. Although if the patient is back out living in the camps, that this wouldn't work. But if, let's say, he would be at Lazarus House, there would be a way to reach him. Maybe have the behavioral health specialist just check in with him, make a call and check in with him prior to his primary care appointment. I often do this with patients that I see in the hospital who go home. I tell them I'm a nagger and that they just have to ask my kids and they'll corroborate that. So I'm going to nag them, just check in, call in to make sure that, they know the appointment's coming and that they're going to be there. And I make the promise and stuff like that. But if we could just have, I think that's important. If somebody's there to kind of nudge them along and let them know that, we do care and we're out here, we're waiting for them to continue on their path.
Mm-hmm. Lots of connection / nagging, right?
Sorry.
Well, and
so, sorry, go ahead.
Yeah. No, I was just going to say, in support, and just talking through, being able to stay connected to him and talking through, pretty anxiety producing all this stuff that's happening to him or that he's perpetrating both. But, how might he manage that somewhat more effectively?
Great.
That's it.
Thanks, Gail. Kevin.
Well, nothing earth-shattering here. Unji has already done that. It's just, I know that in my limited experience, it's just been so helpful to reach out early, as soon as I can, to the team members, and to get, behavioral health and CCT involved right away, to get a fuller picture, and then just focus in on my piece as a family doc.
I think that part of helping him establish reasonable primary care will be being flexible about location and meeting him where he is. Not all of our street medicine folks feel comfortable coming into a traditional clinic setting. So making sure that we are respectful of what he's able to tolerate. I mean, coming into a front desk and checking in and going through all of that is not always a comfortable experience. And, either NHC or Valley Health Partners can help with, enabling services, wraparound care, working with street medicine to establish that address to work on services. But a lot of the work with him will be relationship building and helping to figure out what he's able to tolerate in terms of our caring for him.
Mm-hmm. Mm-hmm. Thanks, Mary. Yeah, and I think that was part of what our street medicine team was really thinking about, that he may have needed a longer lead-in time. And it turns out that, storms and legal systems also are more powerful than our attempts to connect sometimes, but that we can do more. And I think one of the things that was really great was that Yunji was able to come from her CWM morning down to Ripple and just kind of check the scene out and get to meet him and be a familiar face. And we may need to just do more of that for longer, but we'll see. Other thoughts from our, and again, I'm going to keep posting because I know you guys are a wealth of information out there. Our CCT friends, what are your experiences helping people who are having trouble connecting? What are some suggestions for supporting this guy?
I'm just going to say this guy's he's tricky because you have so many other factors that trying to make a plan for how to connect him ahead of time, with care, you've got, like you said, there's the legal system factor of, they're kind of going to be calling the shots, I'm sure, for what's going on for the next foreseeable future. So to try to plan for how to connect him, the only thing in the primary care setting from a behavioral health perspective is, I would say, in my experience, I think the behavioral health specialists, we sometimes end up being kind of the judgment-free zone for a lot of the patients to feel like they can talk to us, whereas sometimes it's a shock to the practice as a whole a little more when you're talking about patient's history, and especially for this guy coming from a long-standing incarceration history from the time he was an adolescent. It's going to be a very different experience for him. So yeah, I mean, this is to try to think of suggestions off the top of my head. I just keep thinking of all the other factors that are kind of pulling the strings for him right now.
Right. Yeah. So I'm hearing you say both recognizing that there are some pretty big forces at work that may get in the way of any good intention, but also hearing you say that one of the positions that you can really hold open for him is stigma-free space, no judgment. Mm-hmm.
Absolutely, you got it.
Yeah. And if I can ask you one more piece of that, what's your sort of top one or two tips for your behavioral health colleagues and for the primary care colleagues? And what's your go-to for when you're feeling yourself get kind of triggered in the judgy zone? How do you reel yourself in?
That's That's a good question. I think from coming at most of the situations we encounter from, like, and I know we all have our own, history of where we've been before we walked into, Lehigh Valley Hospital and took on this job. But I feel like coming from the perspective of having different experiences with different parts of the community and different agencies and, different populations, it kind of wears down your shock factor. So, you have kind of a better starting point maybe than somebody who's like, oh my gosh, we've got all these different things to deal with and it's all new. So I personally, for me, just kind of chalk it up to the experience of, okay, I've seen this before, or, I've worked with this population before and nothing's too off limits.
So this is Gail. To sort of go on that same line is to not judge, is to not be shocked in some ways, or to try to understand the experience the person had. I think it's helpful. I saw Jillian do it earlier, to connect to the suffering. And it helps you not be so judgy. And then don't assume that you know why he's suffering, and then ask him, about it, and, what is your experience and where's your pain?
Mm-hmm.
That's mainly, I think connecting to the suffering so that you understand that they're not doing this just to bother us, if you will, or society or all that stuff.
Yeah, I see some nods and some resonating with that's a helpful tool. Anybody want to comment on that? We got a couple more minutes.
No, I agree with what Gail and Jill said, and humanizing these individuals and meeting them at their level. When even if it's just a comment on what a shirt he's wearing, hey, that's an awesome shirt. Like, how are you doing today? Like, what's going on with you? What can I do to help? Because we have to remind ourselves that we're not experts in their life, and that role reversal will really help us be able to guide them and support them in their recovery and help them.
Great, thank you, Sophia. I'm gonna check in with some of our faculty folks just for a little piece of anything. Jillian, from a med talks point of view, any advice you have or recommendations for Yunji and the team?
I think, not really from a med talks point of view, but just from kind of thinking through the situation. I think, as Mary so eloquently pointed out, coming to an appointment is something, that was sort of our first move. We met him and said, great, our next move is here's your appointment. And putting ourselves in his shoes and everything that we know has happened since. But even if there wasn't a flood, and even if he wasn't incarcerated and he was still in his camp, he did say to us that when we were talking to Nani at Ripple, he did not intend to get off the streets. So my thinking is, how do we, whether he comes and sees us in the ED or is going to be cared for by Yunji, how do we meet a patient where he is if his goal is not necessarily to get off the streets? I think part of him liked the independence. He had his crew, they were living together, they had broken away from another camp, they had their own camp now. They were using together, but there was something about that worked for him. And how do we provide care that meets him in that situation? And I will say that I don't know what the answer is to that when it comes to Valley Health Partners, and but I think there's something there that we should explore. And when I saw Yunji at Ripple, I feel like my heart was going to explode. Like, here is a primary care physician at Ripple, came down here to a drop-in center to meet this person. How amazing is that? Like, I want the Yoonji Chung team shirt from the Valley Health Partners paraphernalia store. So that's my thought. I have more questions than answers, but very heartwarming.
Thank you, Jillian. Yeah, Melissa.
So I think one of the things, we've discussed this case since we met him, actually even before we met him. And one of the things that we have discussed with Nyan was to get a couple of iPads available to be able to wrap around a little bit tighter around him, in the sense of providing that warmer handoff. So allowing the individuals to begin their visits or begin their touches with CRS services, possibly the behavioral health team at Valley Health Partners from Ripple, where they build a level of comfort. So the iPads will be available there, set up even if it's just a 10 or 15 minute visit, where they can check in, see a face, know who they're going to be meeting when they arrive to Valley Health Partners. And again, I'll echo what Jillian said, just seeing Yoonji kind of come out, because we get to see Nani, and we get to, Abby, Nani, and Jillian, and kind of see them step out of their everyday roles and be part of, the street medicine team at times, and see them at Ripple and in the community. But we don't see that all the time. And being in the substance use field for all of these years, this is all new and definitely heartwarming and amazing to know that there are doctors that are available to do this and meet the patients where they're at. So again, it's just that it's making that more available, and recognizing that a lot of these patients that we see, they don't identify as homeless. This is their home, and they're comfortable there. So we can't push our way of, oh, let's get you into a recovery house. We can suggest all of these things, but many are very comfortable. So of course, it's just providing sort of a harm reduction model, and really working with them with whatever they allow us to help them with. So that's kind of one of the ways that we came up with is starting the touches right wherever they feel comfortable coming to meet us at.
Mm-hmm. Thank you. That's such a great perspective. Kevin, do you have anything else that you want to add? You had some great suggestions already, but wanted to give you a chance.
I would also like to place my order for a Yoonji t-shirt.
Mm-hmm.
And not really a suggestion, but just an observation. I have learned so much just participating and listening into these Project Echo calls. So many questions that I didn't even know to ask. So yeah, I just really appreciate that.
Yeah, that's wonderful. Thank you, Kevin. I feel the same way about the Echo, and I think from my perspective as a primary care person, the most valuable tool that I have, and it becomes exponentially more valuable as the patient situation becomes more complicated, is our team. So having Gina and Naomi and Jasmine and being able to reach out to Jillian, being able to reach out to Kate, being able to reach out to Shelley, which we've done billions of times. When in doubt, go to your team. And when you feel, I think for me, what I love about the team in this kind of care is the dance that's available, that when for whatever reason, this case triggers something in me that's not particularly therapeutic, whenever those feelings come up of, oh, this guy is just trying to get over on me, or, oh, he's not showing up because he doesn't care. Like, with all of us have those judgy thoughts from time to time, and experience can help us recognize them earlier and let them go. But they come up because they come from your emotional space of being disappointed that something didn't go the way you wanted it to. That's what happens. So I have my team, and Gina Hills can tell me to cool it, or somebody else can just step in for a minute. I can have one of the behavioral health specialists in our team go just check out the situation and bring me some more information before I walk in there feeling judgmental. So I think our best tool for trauma-informed harm reduction approach is making sure that you've got people around you who care about you and care about the care and care about the patient too. Our last word for today might come from Paige. Do you have any last thoughts for this team and this guy?
Well, I really like what you just shared, Abby, about, you know, the challenges sometimes being non-judgmental and frustrated, which is kind of the beauty of working with someone like Jillian, because she's just so wonderful at being that way. Yeah, I mean, I always try and remind myself, almost as a little mantra, you know, to be kind, you know, to be kind and to be kind. Because at the end of the day, these people are under everything, you know, in pain. And, you know, they don't do it to themselves. It's part of, you know, the disease. And, so that's, I really enjoy being on these calls. And, you know, when Jan and Lisa just shared about the fact that, you know, they are home, even though they're, you know, living in camps. And like those kinds of things remind me that, you know, not everything is black and white. And, you know, I sit in my cozy little house and I need these calls. So that's really my only word. Thank you.
Well, thank you, team. That was rich conversation. That is our one case for today. So my plea out there is if you have a case that you have questions about, bring it forward. We will help you present it in any way that you want help. And that can come from our primary care teams, from our drug and alcohol partners, from our behavioral health partners. Cases can come from any point of view, and just reach out. You can Tiger text me or Jillian. You can email us if you have a question. And I think what I always found with the ECHO when I was first getting started was that presenting a case was the best way to get some guidance on what to do for a particular person. There's always a perspective that hasn't sort of come to you, so it's a great way to learn. And Yunji, thank you for doing it. Really appreciate it. Yep, and you gotta go. So we're gonna transition into our didactic session now. Before I do that, I think there are some people who joined us that didn't get a chance to introduce themselves. Amy, are you out there?
I am out here. And I want a Yunji shirt too.
Great.
We go back to her first day of medical school. So I'm just so excited to see the great work that she's doing. So I'm Amy Smith. I'm a medical educator in the Department of Education, and I am the Select Clerkship Years Director.
Amy, so delighted to have you with us. And Amy, anytime you want to present a case, you're welcome to.
Thank you.
Let's see. Michelle? Michelle.
Hi, I'm Michelle Zapali. I'm a behavioral health specialist for the community care team. I'm in between hubs right now, so I'm just currently home.
Got it. Welcome. Glad you're here. Tommy.
Good morning, everyone. Tommy Acevedo. I'm the behavioral health specialist at the Family Health Center with Valley Health Partners. Great to be here.
Love to see you, Tommy. Terry.
Good morning, Terry Norcott-Gibbons. I'm from Trucks for Town Family Med. I'm the BHS here.
That's awesome. And Terry, I know you have some cases in your orbit. It's great to have you here.
Thanks.
All right, I'm going to try and share my screen. And today we're talking about medications. Okay. So this didactic was created by a wonderful group of people from some of our leaders in addiction medicine and collaborative care around the country. So you can see where they're from up there: New York, Washington, Mexico, New Mexico. Really great people. None of us have anything to disclose. So we're going to be talking about medications for opioid use disorder and for overdose prevention. For many people, this will be a review, but hopefully there's something interesting and fun in there, and we'll try and have a little bit of discussion as we go. So our medications for opioid use disorder, there are 3. We have the methadone, buprenorphine, and naltrexone. Most of the time when you hear people talking about MAT, we are talking about buprenorphine, but it's just important to remember that methadone is a important medication, and naltrexone is too. We talk about buprenorphine a lot because that's the one you need the special X waiver for, and that's the one that we're trying to sort of promote in primary care. But we'll go through all 3 because they all have a really key role in our overall set of tools that we have for helping people with opioid use disorder. So as you know, and this is one of my favorite slides, so I try and use it as often as I can, that the trajectory in addiction, and particularly in opioid use disorder, we go from sort of the acute use phase into a chronic phase. And in the acute phase, people may be using in order to feel euphoria. So when they use, they have the euphoria, and when they don't use, they go back to a normal state, and then they use for the euphoria and come back to normal. But because these the drugs, the heroin, Percocet, oxycodone, because they have, because your body develops such tolerance to them, you can see that this line here of the euphoria goes down, 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 down. They may be chasing, looking for a high that they can't achieve anymore because their body has become more tolerant. And as they develop more physical dependence, they start to not go back to a normal state when they're using, but into withdrawal. So you see in this chronic use phase, people may not be feeling euphoria much at all. They're just trying to get back to feeling normal. And when they're not using, they feel dreadful. And I think dreadful is actually a good word because the fear that goes along with trying to avoid withdrawal really is a sense of dread, that they are not okay, and the only way that they can feel like they can function is to continue to use. So opioids have a powerful grip on people because of this trajectory with the tolerance and the physical dependence. And then we see all of the behaviors and so on and the dysfunction that come along with addiction as the brain adapts to this situation of chronic use and trying to avoid that fearful, dreadful place of withdrawal and physical pain, that the brain remodels itself. And those behaviors and dysfunction, the impulsive and compulsive aspects of the addiction, take over people's lives. So the role for the medication-assisted treatment, rather than saying it's just replacing one drug with another, the goal for medication-assisted treatment is that we're interrupting that sawtooth of up and down, dreadful to normal, and giving people an opportunity to stay stably in that normal phase where they're not in withdrawal and not experiencing euphoria. And what we have found through lots of studies at this point, with from methadone all the way through the naltrexone, is that helping people to stay in that normal zone by treating their cravings and their withdrawal symptoms allows them to engage in recovery activities and to engage in treatment for longer and have a better chance of getting to long-term recovery. We know that there are many people out there who have done it without medication-assisted treatment, but we also have, and respect out there for that, but that these medications help to engage people earlier, longer, and prevent overdose deaths. So here we're talking about preventing overdose deaths, and I don't know if my view is, do I have little fuzzy boxes in the way there? There have been some interesting studies, and one from 2018 was looking at what happened to people who presented to the ERs in Massachusetts between 2012 and 2014. And Jillian will tell you that's the early days for the medical toxicology world and their response to opioid use disorders. This is probably one of the studies that that changed the stage, so that emergency departments, a few across the country, including LVHN, thought, there's something that we need to do, because what they saw in Massachusetts when they looked at that 2-year period, almost 18,000 people presented and survived an opioid overdose. You can't study the people who died, but they looked at what happened to the people who survived an overdose. Did they get MAT? Did they engage in care? Did they have a subsequent overdose or other poor outcome? And what they found was that less than a third of patients did receive any form of MAT after overdose, and that was in a period, looking at a period of about a year. So they didn't engage in care to get MAT. May have been referred. They didn't really have a way to look at that in the study. They may have been referred, but they didn't get any MAT. They didn't get it in the ER. They didn't get it in the community. But for those who did receive MAT, it decreased their chance of death in the subsequent 12 months significantly. So if they did, either through the ER or through linkage to treatment in the community, they survived, whereas they may not have survived otherwise. So I think one of the things that came up with this is that that giving someone a piece of paper in the ER, and Paige can talk about those days, giving someone a piece of paper and saying, go here, that didn't work. But if you do more linkage or actually do some treatment in the ER, that could be a lifesaver. And look at these figures are huge. 59% decrease for people who are on methadone. Methadone saves lives. 38% for the people on buprenorphine. And at that point in 2012 to 2014, not a lot of people receiving naltrexone, and not an option of something that you can do in the ER so that he has an overdose anyway. So that's interesting. And just recently, the Health Affairs article came out looking at North Carolina. And you can see that there's still a big gap in who receives buprenorphine or methadone from the ER, that we have a lot to do to link people to MAT, even from our high risk points like the ER. Okay, so let's talk about methadone briefly. Sometimes in primary care, we forget about methadone because it's not the thing we do. I know we have a really active case right now out in Hamburg about how to connect someone to methadone. But methadone can be important. It's effective. We have data going back decades on increased survival, treatment retention, employment, decreased opioid use, decreased infection, decreased criminal activity, robust literature out there about methadone. It's highly regulated, so must be for people with opioid use disorder. They have to go to an opioid treatment program or an OTP. Those are our new directions, have it off go, step by step. supervised daily dosing, take homes when you're stable. So if you have a patient on methadone, one of the questions that you want to know how they're doing, you ask them if they get any take-home doses. And if they're not getting take-home doses, that means they are still pretty early or not stable in their treatment. They get some counseling, urine testing every day, and psychiatry and medical services are not required in an OTP. So that's another question to ask about. But they may not be getting their whole person care in a methadone treatment program, even though they're getting daily supervised doses. Useful to know that for primary care, it is illegal for us to prescribe methadone for addiction. It has to happen in a treatment program. We can prescribe methadone for chronic pain. Need to be careful about how to document that, and it comes in a different form. So the methadone at a treatment center, who wants to tell me, what does that look like? Physically, what does it look like?
It's liquid.
Right. Anybody know what color our liquid is?
It's pink, right?
Little orange liquid, right? Or whatever.
Pink, red.
So if their methadone is liquid, they're getting it in an OTP. If it's in a tablet, that's prescribed for pain. Those are things that you can ask about for people for methadone. What we know also, and there's some references in the back if you want to see them, that longer duration, higher dose treatment is more effective. We've gone back and forth in our country about policies for methadone treatment programs. I remember when I was a resident, which was quite a while ago, there was a big push in the country to shorten and wean people off of methadone, and it had disastrous consequences. It was in the early 90s. Rapid weans, and people did very poorly. So the policy went back the other way when the evidence came out. Longer duration, higher dose treatment. There have been lots of studies on cost effectiveness, and every dollar invested in methadone treatment, $4 or $5 savings. So methadone's important. To the point where methadone is one of the WHO list of 100 essential medicines that should be available worldwide. Yeah.
Can a primary care physician prescribe methadone? If so, what is the limit of the milligrams that they can prescribe?
So we can prescribe methadone for pain, not for addiction. We will get in big DEA trouble for treating addiction, so you need to be careful about a diagnosis of chronic pain. And we don't often get anywhere near the doses that are needed for treatment for addiction. So usually a top dose would be like 30 milligrams a day. Yeah. And that's a lot for pain, and often fairly sedating for some of our pain patients. So it's not the same. And I think the daily dosing at a methadone treatment program is important, probably because those doses that they're using are so high. All right. What are some of the myths that you have heard about methadone? Any of these sound familiar to you? Give us a shout out. Which ones have you heard or experienced yourself about methadone?
Still addicted.
Still addicted.
That's huge in the recovery community.
Yeah. Do you have a sense of why?
Pardon me?
Why is that such a sticky notion in the recovery community? What's your insight on that?
Well, in NA, they are married to the abstinence is the only way theory. And I think that's very dangerous. And being part of the recovery community, I talk about that all the time. You know, when I ask people, you know, have they read the studies? What medical school did you go to? you know, I think that's something we have to fight really hard in the recovery community and with people who come in and say, well, you know, it's just exchanging one substance for another.
Mhm. Thanks, Paige. What else have we heard for myths?
Definitely the part that it weakens your bones or it gets in your bones. I definitely heard that while I was working at the methadone clinic.
Yeah, I had somebody say that to me just last week about buprenorphine, actually. It's in your bones. So we talked about that a little bit. I don't know where that one comes from as an idea. I think that it's difficult to, if I'm making something up, it might be that the withdrawal from methadone is sort of prolonged and takes a long time. I might feel like it's in your bones. It certainly hurts like it's in your bones when you're withdrawing.
Yeah, a lot of it was that it's because of the half-life being so much longer than other opiates. Many would say exactly that it's in your bones, it takes longer to come out, and when they get the joint pains, again, it goes back to feeling it in their bones.
Right. And methadone is one of those medications that different people metabolize at different rates, so it's hard to predict exactly how long your withdrawal syndrome is going to be. Any other myths out there?
That people frequently abuse the medication.
Right. Yeah, and I think that one's sticky in primary care and in the recovery community because the people that we see are the ones who don't do so well on methadone. If you're doing well on methadone, you stay in your methadone program, and we may not hear about it in primary care. So we have a really skewed view and a skewed sample. And I think also in abstinence-based drug and alcohol treatment programs, we don't tend to see the people who are doing well on methadone because that's not who's there. And in our behavioral health world, with our carve out for substance use disorder treatment versus behavioral health treatment, you also may not be seeing people in your practice who are doing well on methadone, but there are people, thousands of them across the country who are being maintained on methadone and living productive lives when nothing else has worked for them. So that's our methadone intro. That's it. But keep in mind that for people, you know, this is useful, and we can always refer people to our methadone program when they need it. Buprenorphine came on the scene in about 2002, and in 2000, the legislation, the data 2000 made it legal for primary care to prescribe or for prescriptions from doctors outside of the opioid treatment programs. And the studies that compare buprenorphine to methadone show that it has similar effects for abstinence from illicit opioids, decreased cravings, treats your withdrawal, somewhat lower retention in treatment. And some of the thoughts about that are that with less structure, either people need a whole lot more structure to be well, or people who are less ready for their recovery journey are in these other settings with less structure, and there's a little bit less retention. So that's one of our big questions for ourselves is how do we support retention for people who are on buprenorphine in practice? And we know it takes a team and a village to get that done, as our case today was illustrating for us. How it works is as a partial agonist. So it's a little bit safer than methadone. And I think my next slide has a visual to go along with that. And it has a higher receptor affinity that has, that really binds strongly to the receptors. So when buprenorphine comes to a receptor, the high affinity means it's really attractive, and the buprenorphine will knock any other opioids off of that receptor. It's really sticky, so it'll stay there for a long time, and it only sort of partially activates that receptor. So those three things make it a useful medication. It comes in the sublingual dosing. You'll hear people talking about the films that they put under their tongue. There's an implant that we don't use particularly often. Jillian, I don't know if you know anybody that's using the implant, but it's pretty low dose. So not really using that. And then there's the injection, the Sublocade. We're offering that at neighborhood health centers. I don't think any of our partners out in the LVPG world are doing that, and I don't know about any of our other programs that are doing that. Gina, do you know if there's anybody else in the community that's doing Sublocade right now?
Daniel Hernandez in Quakertown is a private practice. I'm not sure what network he's affiliated with, but he is not accepting any more MA patients at this time, which kind of stinks. And A Clean Slate is trying to get it off the ground. Treatment Trends was asking questions about it, but I don't believe, and Shelly just gave me the signal. I don't think that they're up and running with it. So currently we're like one of the only practices that do it.
Mm-hmm. Great. And I think the most important thing to know for our behavioral health partners out there is about precipitated withdrawal. So for patients who are dependent on the opioids and experience withdrawal when they are not using, that if they use their buprenorphine too early, that knocking the opioid off the receptor and replacing it with a less active buprenorphine, that can cause some very uncomfortable withdrawal. So when we hear about people saying, oh no, that doesn't work for me, it makes me sick, oftentimes that's because somebody tried it at home and they tried it too early when they weren't in enough withdrawal already. So it's useful to be able to unpack when someone says, oh no, that doesn't work for me. What happened? Was it that they had some precipitated withdrawal? Were they not taking the medication effectively? Did they need more structure? What do they mean when they said it didn't work for them? Any questions about that so far? This slide is mostly showing that, we've got our full agonist, means it sits on that receptor and does exactly, has a full effect, and the effect is some euphoria and then eventually respiratory suppression, so that methadone has the possibility of an overdose. In general, we say that ceiling effect with buprenorphine as a partial agonist is below that point of respiratory suppression and death. That's not true though in certain cases. Does anybody know when is it not true that there's a ceiling effect for the buprenorphine? What do you think?
So little kids.
Little kids, that's right. So little kids don't, for some reason, have that ceiling effect. So it's very important that if there are kids in the house or kids that come to the house, that people are storing their medication in ways that are not attractive to kids, away from kids. What else? What about if they're using alcohol? Or what else?
Would it be with benzos?
That's right, yeah. So alcohol and benzos, when we see overdoses, and Jillian's our expert on this, usually it's with alcohol or benzos on board also, and sometimes other drugs. What about cocaine or meth? Does not affect that ceiling effect. Not that we would say it was safe, but it doesn't increase the risk of overdose from the buprenorphine. So we love to talk about this study from 2003, one of the studies that kind of launched the office-based treatment program across the country. This is a little study from Sweden where they looked at buprenorphine versus placebo. We can't do that anymore, but this study looked at 40 people, randomized them to either get buprenorphine at 16 milligrams a day versus a taper or placebo. And everyone received individual counseling in groups. They followed them for a year. And this, I think, speaks pretty plainly that in that group, when you look at the folks who, when you look at your two outcomes, who was still in treatment, none of the ones who were on a taper or placebo were still in treatment at a year, but 3/4 of the people who were receiving the buprenorphine were. When you look at who died of an overdose, it's horrible that 1 out of 5, and so that's 4 people died of an overdose that were in the placebo group, and there were no overdose deaths in the buprenorphine group. These results have been shown to bear out in lots of other studies in one way or another that increased retention treatment and decreased overdose deaths. But in our primary care world, we never get a grid that looks like that. We don't have medications that are this effective for other chronic diseases. This is a powerful tool for our primary care practices. So let's talk about what that looks like in primary care right now. The PACMAT group is supporting MAT in primary care at about 14 different practices right now. It's been slow progress, right? There's been issues with stigma, competing priorities, and a lot of change fatigue throughout the whole COVID era. But we're getting there, and if each practice was able to take on 10, 20 patients, that would improve access to buprenorphine in our communities across the 7 counties by hundreds of patients. At NHCLV, we've got a team approach that was started in January of 2017 with the COE. We have how many patients right now, Gina?
Active, we have 254. Throughout from January of 17 till now, we've seen over 860.
Mm-hmm. So think about that, Valley Health Partners. You can be there too sometime. And then we did have a program with Lehigh Valley Health Network and Pyramid that's evolving. I don't know, Jillian, if you wanted to sort of talk a little bit about how that's evolved.
Yeah, sure. So Pyramid, it still has an MAT clinic, but they are staffing it with internal advanced practice clinicians from their inpatient setting right now. So while our toxicology group is no longer staffing their clinic, we are still referring patients who desire follow-up at Pyramid for MAT.
Mm-hmm. Right. And as we build the primary care network through LEPG and Valley Health Partners and continue to work with NHCLE, hopefully there's more sustained treatment for people that you're seeing in the ER. Okay, naltrexone. Our other name for naltrexone is the Vivitrol. So the injections, there's also a tablet form, the Revia, but our studies show that the injection is more effective. And this one, so we had methadone as our full agonist, has a full effect at the mu receptor in the brain. Buprenorphine was our partial agonist, sticky and strong. Naltrexone is our full antagonist. So it also will go to that receptor in your brain. It has has a strong affinity also. It'll knock everything off of the receptor and it'll stay there for a long time, so that if somebody continues to use any opioids while they're on the naltrexone, there's something blocking it in the way that's basically inert. So it can stop the cravings and block those effects. The biggest challenge we have with the naltrexone is that if people are dependent on opioids at all, it'll cause some acute withdrawal. So that's a challenge of how to get somebody started if they're actively using. No physical dependence or withdrawal when people stop. So that's something that in our communities, people are interested in being able to be on this medication because it's easier to stop it than it is to stop methadone or to stop buprenorphine, which both require sort of long, careful tapers. And those tapers are so difficult that we don't even necessarily have that as a goal for people. But the naltrexone, you don't experience any discomfort when you stop, other than a recurrence of craving. Has a lot less stigma attached to it in the recovery world. I think partly because it is a antagonist. Early on, I think there was still a lot of stigma about it, and we've seen a shift and education. But early on, people thought that it was an opioid also, and that's still something that sticks around in the community brain. I see Paige is sort of nodding a little bit that there's less stigma for this one. You want to say anything about that?
Definitely, I think as word gets out, people are more willing to try, or be a first. So that's a good thing.
Yeah. And it's interesting that naltrexone, and I think things are starting to catch up with each other a little bit with the state policies about MAT in the jails and prisons that we were talking about just a little while ago. The state prisons are offering MAT treatment to continue whatever treatment someone was on when they're incarcerated. But for a long time, they were not offering buprenorphine or and only offering to maintain some people on methadone and mostly just pregnant women on methadone. And naltrexone for people, it was heavily marketed and had a huge, it was a marketing strategy to have Vivitrol in the jails and prisons, and I think played on some of the stigma that people shouldn't get a reward when they're in jail, and that methadone and buprenorphine were considered a reward. But naltrexone was their marketing that this isn't a reward. You can still punish somebody and give them Vivitrol. So it was an easier match of a story in the criminal justice systems than buprenorphine. But luckily, things are starting to slowly change. When we look at some of the data for naltrexone, the effectiveness for people with opioid use disorders is comparable to buprenorphine if you can initiate the treatment. And that's the big capital if. So we've mentioned that people need to be completely detoxed from any opioid before they can start the naltrexone. And that's a challenge. And when you combine that with the stigma that's out there in multiple different parts of our community about other forms of MAT, we have a pretty sizable population of people that are actively using this and say, I want only naltrexone. And they're going to have a bumpy road for how to get there. We don't have great methods for outpatient detox. We can offer comfort medications. And you've heard from Jillian before that what we often do for comfort medications for outpatient detox is clonidine, hydroxyzine, and something for nausea and vomiting and pain, so ibuprofen, Zofran, etc., Imodium. So we can offer all those comfort medications for someone for outpatient detox, but it's tough. So people have a really hard time getting past 4 or 5 days when the withdrawal really sets in. So I would say at NHCLV, we recommend against trying to do the home detox because people don't succeed very well, and we're just delaying treatment and putting them at pretty high risk. Try to get them to inpatient detox, but our inpatient detox programs aren't really set up to help us do this either. They're mostly 5-day rapid detoxes now, and they use some buprenorphine to help in that detox. So when they come out of detox, they're not completely ready for Vivitrol or naltrexone either. So our experience is similar to what we see in a lot of the rest of the community that's been studied, that that there's a high dropout rate prior to initiation of the medication. And that's how they explain the decrease in the lower effectiveness overall for naltrexone, is that that there's just a lot of dropout. So that population then doesn't do as well. Once you get there, it's effective. And what's nice about it is that there are a couple of things that are useful about naltrexone. You can use it in our office-based primary care settings or in treatment settings without any added training. You don't need an X waiver like you do for buprenorphine. You don't need to be in office opioid treatment program like you do for methadone. You can use it anywhere as long as you have a medical license. But the caveat that our literature suggests is that it may have even less structure than office-based buprenorphine that has more frequent visits. It's a once-a-month visit. People may need more support than just a once-a-month visit, and that may also explain why people tend to drop out more often. Any questions about any of those 3 medications or any comments? And I hope some of that's helpful just for knowing what are the medicines we're talking about and why do we use them and why do we choose them when we do. The last thing that I want to talk about is the overdose prevention. And that's our Narcan. And you guys all know about Narcan. Okay. So naloxone or Narcan is also antagonist, a full antagonist, and it will reverse the opioid overdose. It has a relatively fast and short action. So we can educate our community about Narcan and naloxone, how to find it, how to use it. Important to help our make sure that people who are at high risk of an overdose, that not only do they have the Narcan or the naloxone, but their friends and family know how to use it too. So when we talk about overdose prevention, we're talking about having the naloxone available to as many people as possible and the education to as many people as possible. I think people are aware at this point that there's a standing order for naloxone in Pennsylvania, so anybody should be able to go to any pharmacy and get a prescription, and it should be covered by their insurance. Early on, the acceptance of that was relatively low, and we've heard people say, oh, the pharmacy didn't have it, or they didn't give it to me, or they charged me out of pocket. Sometimes the co-pays for people with private insurance are pretty high. But there is a standing order. It's also standard of care in primary care, and Kevin can speak to this and does frequently, that anyone who is prescribed an opioid of any kind should also be prescribed Narcan. And when we look at quality programs, that's one of the markers we look at. Did we prescribe the naloxone? And if there's a way of knowing, can you even did they pick it up? Do they have it? Those are sort of the key. We prescribe naloxone for all of our patients who are in treatment for opioid use disorder. And many people look at you kind of funny and they're like, well, but I'm in remission. Why would I don't need that anymore. So we do a lot of education with people about you may be someone that's in a position to save somebody else's life. It's good to know how to use it, and we do the harm reduction about making sure that people know, because recurrence happens. So always having some on hand and knowing how to use it. When we look at the SAMHSA overdose prevention toolkit, which I encourage you to look at if you haven't seen it already, there are a lot of other great strategies to think about who's at highest risk for overdose, who needs who do we need to be reaching out to specifically. Some of the programs that get mentioned in an overdose prevention toolkit are the value of syringe exchanges, that if we are doing a harm reduction approach and are able to reach people who are actively using, just having the giveaways and making sure that people are educated there. As we all know, we do not have syringe services in the Lehigh Valley, but someday perhaps we will. Other high-risk moments are, and this for our guy that we talked about today, when you're released from prison or jail, if you've been forced to detox in jail and your tolerance is down, but you have not committed to recovery and you're not ready for treatment, those first days out of jail are really dangerous, because people will go back and try and use the way they had used before, and their tolerance is much lower. So we know that those days are dangerous. That first week is high risk. We want to be able to get naloxone to everyone. And Shelley and Gina, do you know, do they provide a prescription or dispense or educate on release at this point? Is that part of the program or no? Who knows?
Yeah, so if you're talking about like state-wise, no, they don't. One thing I did want to add though, while you were talking, was that for PACMAT and the practices that accept private insurance, Bethlehem Health Bureau has an abundance of naloxone kits that they were supposed to be giving to schools, first responders, paramedics, police, and they can't seem to get rid of them. Each kit has 2 doses, 4 milligrams in it. And if you are part of a practice that has people with private insurance or uninsured patients that can't afford naloxone, you can go ahead and contact Kristen Wenrich at the Bethlehem Health Bureau, and she can give you some of those kits so that you have them on hand for your people.
Gina, and as I'm looking at who's up on the tiles up this way, Valerie, I'm wondering if it would be interesting to be able to stop some of the primary care practices that you work with naloxone. We will definitely provide that contact info. Jillian, do you want to talk about the naloxone giveaways that you've been part of?
Yeah, sure. I mean, so we have a Fleming-funded program in the ED for underinsured or uninsured patients where we can provide a kit. We break up the kits that Gina's talking about and just give one of the nasal sprays, which is 4 milligrams, which, as it turns out, is 100 times the dose we actually give in the ED. So it's a massive dose. And we also, Paige and myself and Street Medicine and a bunch of other volunteers for the network have done a number of naloxone giveaways in the community for LVHN and Street Medicine at Rally in the Valley and various other recovery events. So we're trying to get kits out there. I will say that I think there's been a tremendous push to get kits into the hands of lay first responders, so teachers, librarians, gas station attendants, which I think is awesome. But I think one thing that we're missing still is getting those kits to patients. And because of, Gina mentioned private insurance, if you're privately insured, sounds like you're in great shape, but your co-pays might be like, $60 for the kit, completely unaffordable. And they're over $90 if you pay cash for them under the standing order. So I think we still have a big gap to fill. And if all of us can remember to try to get kits into people's hands in the clinical setting. I think that'll help get kits into the hands of the people who need it most, who are people who are actively using substances.
Thanks, Jillian. Yeah, so, and we think about who are the people that are at highest risk. And some of these things, when I was first learning, felt counterintuitive to me that, people who use alone are at high risk of overdose. So talking to people about that and making sure that they're not as alone as their habit might make it. How do you use with somebody else? How do you make sure that somebody knows when you're using so that they've got Narcan and they can check on you from time to time? And for some folks that won't feel comfortable or useful, but it's a great conversation to have, whether you're the behavioral health specialist that's working with that patient or the primary care, to say, we care about you. We know that you're not ready to stop using right now, but we want you to be safe. How can we help you do that? Being able to talk about the harm reduction and overdose prevention, I think is really important for us. Early in the journey, it's a way to be able to focus on a thing we can do that makes a difference at a moment when we are going to tend to feel powerless. So rather than feeling frustrated and directing that at the patient that they're still using and not ready yet for all these great tools that we have that we're ready to direct toward them, that we can at least talk about clean needles and safe injecting practices, including overdose prevention. So that's really important. And I think that for us as team members, knowing that that's really critically important information to share. This isn't sort of a throwaway moment. This is really huge. So that's our talk for today. Takeaways are that medications matter. They can make a difference by helping people engage in treatment longer and prevent overdose death. That methadone and buprenorphine appear still to be the most effective pharmacotherapies for opioid use disorder, not because the naltrexone isn't effective, but because it's hard to initiate and because there's a little bit less retention. Naltrexone is great for people who are not currently physically dependent on opioids, and then our overdose prevention, so the important role of naloxone. And I guess my parting thought, as you were talking, Jillian, about the barriers for folks with private insurance is also the barrier for some of the medication-assisted treatment for people with private insurance, that they're not covered as well as they are for people with Medicaid, and that's a real problem. We've had one of our cases, Terry, not Terry. Who covers the Southside practice from the CCTs? But the case that we heard at the ECHO last time or the time before, a patient who really wanted naltrexone and actually did succeed with the home detox and was 14 days abstinent of opioids, and then to find that the naltrexone wasn't covered by her insurance and was going to cost $1,500. That's a massive barrier. So,
but if you reach out to Alkermes, they have a program that you can fill out a form, and I believe they do it like up to maybe $1,100 off. So there might be a way that you can get it either free or at a very reduced cost if you have private insurance that doesn't cover it.
Yeah, and sometimes they've been able to do samples also. Jasmine, what's the limit for duration that Alkermes will cover? Do they, for Vivitrol, yeah.
They can be regular insurance?
No, when they, for the compassionate use or the patient assistance program.
It depends because they use like a periphery, like an outside, but they use anywhere between 6 to 12 months.
Right.
They'll tell you.
6 to 12 months.
And then you can reapply.
Right. So those are our tricks of the trade for our nursing partners and the behavioral health folks to for our resources to know where to go to for that. But you have to stay on top of those applications and make sure that that gets done. And I don't know, especially for virtual, because they use funds from other companies. So if those funds are done, then patients are put on wait lists. So it is one of those things that don't be surprised if patients have to wait a little bit. But they usually are more than happy to help find another resources to do it for a long time. Yeah. All right. So we've got lots of resources. These will all be posted on the NHCLV site. What are some thoughts and questions? Oh, I see it's actually 9. Great. So shall we do our one-word checkouts? Ready? Let's start with Shelley.
Grateful.
Jillian. One-word checkout from Jillian.
Also grateful.
Yamalisa.
Excited.
Gina. Gina Hills. Mute. Still on mute. Can you unmute her? Oh, actually, speak now, Gina. Take 3.
Oh, peaceful.
Wonderful. Sophia.
Very grateful.
Judy.
Even though I came in a little late, I'm happy to see everyone, and this was a good refresher.
Great to have you. Frank.
First word that popped up to my brain was compassion. So compassion.
Good one. Terry.
Inspired.
Let's see. Paige.
Pleased.
Diane.
Resources.
Let's see. Who have I missed that's still here? Keeps jumping around. Jasmine. Naomi. And let me send us off with motivated. Thanks for joining us, everybody. We'll send out the resources and suggestions. Thanks for sharing so many resources. Great to see you all. We'll be back next month on the, what's the date? September 16th. September 16th, same place. Please send cases. Lots to discuss. There is no case too humble or too complicated. We got you. Don't forget to fill out your evaluation. The CME and so on depends on those evaluations, so please fill those out when you get them. And for those who have participated in 3 echoes, you should have or be receiving your $50 bonus prize sometime real soon. Folks who are LVHN employees, that'll come in your paycheck, so you may not notice it, but it's coming to you. And people who present a case are also eligible for their $50 incentive, and those will be coming out soon too. Anything else I missed, Naya? Naomi? Jazz? Go out and have a great day. Heal the sick. Bye.
Thank you, everybody.